Now, another important question, most of the time they ask you about the inguinal canal and the inguinal hernia. Okay, now we'll discuss that. Now, inguinal hernia. Inguinal hernia is a protrusion of the loop of the small intestine into the inguinal canal. It is termed as inguinal hernia. It presents as a swelling above and medial to the pubic tubercle and above the inguinal ligament. Okay, there are just two types of inguinal hernia. One is a direct inguinal hernia and the indirect inguinal hernia. So they can ask you difference between the direct, or they can ask you, give you the description of the swelling, and they can ask you to identify which type of hernia it is, direct, and whether it is direct or the indirect. Okay. So indirect inguinal hernia, also called as oblique inguinal hernia, the herniated loop of the small intestine, it will pass through the deep inguinal ring into the inguinal canal. It may emerge through the superficial inguinal ring and descend into the scrotum. When the hernia reaches the scrotal sac, it is complete, and when it remains in the canal and does not pass through the superficial inguinal ring, it is said to be incomplete. Okay. This type of hernia is more common than the direct inguinal hernia. It can be congenital due to patent processus vaginalis, or it can be acquired due to increased intra-abdominal pressure as during weightlifting. The neck of the hernial sac lies lateral to the inferior epigastric artery. Okay, so this is very important. This neck of the indirect inguinal hernia lies lateral to the inferior epigastric artery. Okay, while now see the direct inguinal hernia. It pushes its way into the inguinal canal directly through the posterior wall of the inguinal canal through the Hazelberg triangle. Okay, so what is this Hazelberg triangle? So they can ask, this direct inguinal hernia is coming from where? It is coming from the superficial inguinal ring, whether it is coming from the deep inguinal ring. So it is coming from the posterior wall of the inguinal canal through the Hazelberg triangle. Okay. The neck of the hernia lies medial to the inferior epigastric artery. So this direct inguinal hernia, the neck of the hernia is lying medial to the inferior epigastric artery, while indirect it is lying lateral to the inferior epigastric artery. So these questions they can ask you. So what is the difference between the indirect inguinal hernia and the direct inguinal hernia? Here the viscous enters the inguinal canal through the deep inguinal ring. The neck of the internal hernial sac is narrow. Relation to the inferior epigastric artery, it will lie lateral to the inferior epigastric artery. The neck of the hernial sac will be lateral to the inferior epigastric artery. It is seen in young people, and reason is generally it can be congenital due to the persistent processes vaginal. While direct inguinal hernia, here the viscous will enter the canal by pushing forward the posterior wall of the inguinal canal through the Hazelberg triangle. The neck is wide. Okay, neck of the hernial sac will lie medial to the inferior epigastric artery. It occurs commonly in the old age. It is usually acquired due to the weakness of the muscles forming the posterior wall of the inguinal canal. Okay, so that is what is the difference between the indirect and the. Now, what are the coverings of the inguinal hernia? Okay, in the indirect inguinal hernia, you have the skin, the superficial fascia, external spermatic fascia, the cremastic muscle and the fascia, internal spermatic fascia, and the extraperitoneal tissue. Okay, the same content are there in the direct hernia also, except this internal spermatic fascia. Okay, the contents are same. You have got the external spermatic fascia, cremastic muscle and fascia, and the internal spermatic fascia in the indirect. So only this is not there, but while rest of the contents are same. So direct does not have the internal spermatic fascia, which is derived from the fascia transversalis. Okay. See, this external spermatic fascia comes from external oblique aponeurosis. Cremastic muscle and fascia is coming from the internal oblique. So it is same here. Okay. So internal spermatic fascia present only in the indirect hernia, while direct hernia does not pass through the deep inguinal ring, and the cremastic muscle may be absent in the medial direct hernia. And this cremastic muscle, this direct hernia is also divided into medial and lateral. Okay, so in medial, this cremastic muscle is also absent. Okay. So this is the Hazelberg triangle through which this posterior, this is the direct inguinal hernia will pass through this posterior, this triangle, which is called as Hazelbus triangle. Okay, it is located above the medial half of the inguinal ligament. So boundaries are laterally, here is the inferior epigastric artery, and medially by the lateral border of the rectus abdominis muscle. Okay, so medially you have the lateral border of the rectus abdominis muscle, laterally you have this inferior epigastric artery, and inferiorly you have the inguinal ligament. So that forms the Hazelbus triangle. The apex is formed where the inferior epigastric artery will meet the lateral border of the rectus abdominis muscle, and the floor is formed by the conjoint tendons and the fascia transversalis. This is what is the Hazelbus triangle through which the direct inguinal hernia will go. Okay. Now coming to the inguinal canal as such. Now what is an inguinal canal? It is an oblique intermuscular passage in the lower part of the anterior abdominal wall for the passage of the spermatic cord in males and the round ligament of the uterus in females. There is always one SBA regarding the content of the inguinal canal. Okay, so listen carefully. Inguinal canal, it is an oblique intermuscular passage in the lower part of the anterior abdominal wall for the passage of the spermatic cord in males and the round ligament of the uterus in females. What is the location? It lies half inch above and parallel to the medial half of the inguinal ligament. Okay, half inch above and parallel to the medial half of the inguinal ligament. In adults, the canal is directed downwards, forwards, and medially. Okay, in newborns, the canal is directed forwards. Okay, so extent is around 4 centimeter. It is long and extends from the deep inguinal ring. So deep inguinal ring is here. The superficial inguinal ring is here. So in between these two lies this inguinal canal, and it will transmit the spermatic cord in males and the round ligament in females. Okay. So what are the boundaries of inguinal canal? Anterior wall is formed by the skin, the superficial fascia, the appendices of the external oblique muscle, and in lateral 1/3 by the fleshy fibers of the internal oblique muscle. Okay, so that forms the anterior wall of the inguinal canal. The posterior wall is formed by the fascia transversalis. Medial, in the medial half, in front of the fascia transversalis by the conjoint tendon, and medial 1/4 in front of the conjoint tendon by the reflected part of the round ligament. Okay, so the reflected part of the inguinal ligament. This inguinal ligament has got certain extension. Okay, so the one of the extension is the reflected part of the inguinal ligament. So that is forming the posterior wall. Okay, and in medial half it is also formed by the in front of the fascia transversus by the conjoint tendon. Roof is formed by the arch fibers of the internal oblique and arch fibers of the transversus abdominis, and floor is formed by the grooved upper surface of the inguinal ligament and medially upper surface of the lacunar ligament. Okay, so this is what is the boundaries of the inguinal ligament. Okay, I don't know whether the question is asked on this, but I feel that these boundaries are going to be very, very important, especially the posterior wall, which is formed from the transversalis fascia in the medial half in front of the fascia transversalis by the conjoint tendon. So you have fascia transversalis, you have got a conjoint tendon, and also the reflected part of the round ligament. So these three structures are there posterior. Okay, and roof is formed by the internal oblique and arch fibers of the transversus abdominis. Okay, so external oblique is coming here, even the internal oblique is also coming here, and internal oblique also coming in the roof also. Okay, so inguinal canal, so coming to the inlet and outlet. Inlet is known as the deep inguinal ring. Okay, it is an oval-shaped depression opening into the fascia transversal. This also they ask you what is the location of the inguinal ring. So it is nothing but the depression in the or opening in the fascia transversalis. It is situated half inch above the mid-inguinal point, is lateral to the inferior epigastric artery, and structure passing through are the spermatic cord in males, round ligament of the uterus in females, and genital branch of genitofemoral nerve. This is very frequently asked single based answer question about the deep inguinal ring. So which structure passes through the deep inguinal ring? The spermatic cord in males, the round ligament in females, and the genital branch of the genitofemoral nerve. Okay, genital branch of the genitofemoral nerve will pass through the deep inguinal ring, and outlet is known as the superficial inguinal ring. So here is a superficial inguinal ring. So it is a triangular gap in the aponeurosis of the external oblique aponeurosis. Okay, so external oblique aponeurosis, there is a gap. That gap, triangular gap, will form this superficial inguinal ring above and lateral to the pubic crest. Okay, structure passing through are spermatic cord in males, round ligament in females, and ilioinguinal nerve. Remember, here it is the genitofemoral nerve which passes through the deep inguinal ring. But what comes out through the superficial inguinal ring is the ilioinguinal nerve. Okay. Sometimes they can ask you that this nerve passes through the superficial inguinal ring. So, okay, superficial inguinal ring, you this ilioinguinal nerve passes, while deep inguinal ring you have the genitofemoral nerve. Okay, genital branch of genitofemoral nerve. Okay. Now, contents of the inguinal canal. In males, it is the spermatic cord and ilioinguinal nerve. In females, round ligament of the uterus and the ilioinguinal nerve. And most important sentence, ilioinguinal nerve does not enter the canal through the deep inguinal ring, but it does so by piercing the internal oblique muscle and comes out through the superficial inguinal ring. So it is actually not going from here to here. It is coming posteriorly, piercing the internal oblique muscle and then coming out through the superficial inguinal ring. That is why it is exiting through the through the superficial inguinal ring, but not going through the deep inguinal ring. Only genital branch of genitofemoral nerve and spermatic cord and round ligaments will pass through the deep inguinal ring. Okay, so there are certain protective mechanisms that prevent the inguinal hernia. Not very important from examination point of view. I'll just read this out. Okay. Opposite the deep inguinal ring, the anterior wall of the canal is strengthened by the fleshy fibers of the internal oblique muscle. Okay. Opposite the superficial inguinal ring, the posterior wall is strengthened by the conjoint tendon reflector part of the inguinal ligament. Okay. So basically, there is a strengthening of the posterior wall at two places. The hernia will come mostly from posterior side. Okay. So it is strengthened at the level of the deep inguinal ring also. It is strengthened at the level of the superficial inguinal ring also. At the level of the deep inguinal ring, you have the fleshy fibers of the internal oblique muscle. At the level of the superficial inguinal ring, you have the conjoint tendon and the reflector part of the inguinal ligament. Okay. Then obliquity of the canal itself will cause the flip wall mechanism. During increased intra-abdominal pressure, the posterior wall comes in contact with the anterior wall and the canal is obliterated. Okay. Contraction of the arch fibers of the internal oblique and transverse abdominis. These fibers are going from below upwards. So when they contract, what they will do? They will bring the roof in approximation with the floor like a shutter. That is called a Keith's shutter mechanism. Okay. So contraction of the external oblique muscle tends to plug the superficial inguinal ring. In males, contraction of the cremaster muscle pulls up the spermatic cord and plugs the superficial inguinal ring. That is the ball valve mechanism. And contraction of the external oblique brings the two crura of the superficial inguinal ring close to each other. That is the slit valve mechanism. So you have slit valve mechanism, you have ball valve mechanism, you have got a shutter mechanism, then posterior wall strengthening at two places and obliquity of the canal itself. So these are the total 6 mechanisms